Hello and welcome to my e-learning tool. In this video, we'll get to know some brief knowledge about colorectal cancer. We'll understand the risk factors, stages of cancers, and diagnostic techniques. Colorectal cancer, as the name suggests, is cancer related to the colon and rectum. It is the fourth most common cause of death among all cancer-related deaths. The survival rate is inferior in developing countries because of the disease's late diagnosis and limited healthcare access. On the other hand, the prognosis is relatively good if diagnosed in an early stage. The key to a good prognosis is early detection due to proper widespread screening, progress in therapy, and incidence changes. Various risk factors are associated with the disease establishment, and minor lifestyle adjustments can make a major drop in incidence. The risk factors that are found associated are widely divided into modifiable and non-modifiable factors. First, let's discuss the non-modifiable factors, or one can call them host-dependent factors. Age is a non-modifiable factor, and the incidence and death rate increases as the age increase by more than 50 years. Secondly, the ratio of cases of colorectal cancer is found more in males. Good evidence clearly states huge variation in disease occurrence among different ethnic groups, races, and geographical areas. The incidence of colorectal cancer is high in developed countries. In 5% of colorectal cancer cases, there is an association with genetic disorders like Lynch syndrome, adenomatous polyposis, Peutz-Jeghers syndrome, and others. Family history plays an important role as a first-degree relative with a history of colorectal cancers predisposes an individual to double the risk of developing colorectal cancer. When we talk about cancers, we cannot afford to forget about past personal history. This obviously includes previous polyps that are mostly diagnosed accidentally during routine screening. This is how routine screening plays an important role in the detection of colorectal cancers. Guidelines claim that physicians should remove any polyp discovered during routine colonoscopy until it has contraindications. Other personal history events include inflammatory bowel disease, pancreatitis, adenomatous polyposis, and previous radiation exposure. Coming forward to the modifiable factors or the host-independent factors which can be controlled or changed to decrease the risk for developing colorectal cancers. One critical factor that plays an extremely important role is diet. Increased intake of vegetables and fruits somehow results in increased intake of dietary fibers and nutrients that is found protective against colorectal cancers. Red meat consumption increases the risk by 22%. Smoked or barbecued meat is found associated with it produced byproducts that are carcinogenic. Calcium and dairy products are protective and reduce risk up to 35%. Fish is also protective. An increase in garlic consumption is found beneficial. Cigarette or tobacco smoking increases the risk. Alcohol consumption is found on the faulty side, increasing 21% risk in moderate drinkers and 52% risk in heavy drinkers. Drugs that are found associated with colorectal cancers are as follow. So, why is staging so important? Knowing how far a cancer is spread tells us about what treatment might be useful. In general, if cancer hasn't spread outside its point of origin, it may be suitable to cut out with surgery or might be suitable to use some radiotherapy. If it's spread, it is far more likely that it will require a systemic treatment like chemotherapy, biological therapies, and hormones. Being able to describe tumors in a standby system, doctors are able to communicate about the extent of cancers more accurately and also groups similar people together when conducting research to compare how effective certain treatments are. It also allows first standardized guidelines to be developed, which can suggest the most appropriate treatment for patients with a particular stage of cancer according to the most up-to-date research. So most commonly used system is the TNM staging. The TNM stands for tumor, node, and metastasis, and it's basically a way of describing how far the tumor has spread. The T stands for a tumor, which is the extent of the primaries of the original tumor. A node refers to how many lymph nodes the tumor has spread to or cancer has spread to. M stands for metastasis, which means whether there are secondary tumors in any other part of the body. So firstly, I'll start with the layers of the bowel, that will help to relate the stages of cancer. So here we can see a cross-section of the bowel, so the bowel is made up of a number of layers. The innermost layer of the bowel is the mucosa, submucosa, muscle layer, subserosa, and serosa. If the tumor invades only the mucosa and submucosa, we label it as T1. If it enters the muscle layer but it doesn't go all the way through, we label it as T2. If it enters the serosa or subserosa through the muscle layer, it is T3. If it goes through the muscle to the extent to which is actually outside the colon, it's labeled as a T4 tumor. Next stage, if cancer has not spread to any of the local lymph nodes, it's labeled N0. If it spreads to 1 to 3 local nodes, it's called an N1 tumor. If it spreads to 4 or more, we label N2. Finally, the M, which stands for metastasis, quite simply, if there are no distant metastases, we'll label it as M0. If there are distant metastases, it is an M1. Let us work on the diagnostic tools and criteria. So how we can diagnose if someone has colorectal cancer? It can be always in two ways. Whether a person will develop symptoms or disease can be diagnosed in the early stage when the symptoms are not really present. If it always better to diagnose the disease in the early stage, as mentioned in T&M staging also. The treatment outcomes are obviously better and a good prognosis can be expected. So, the first step we can plan toward the diagnosis of colorectal cancer is occult blood testing in the stool. The agents involved in this test react and give result positive only if they find some fresh blood in the stool. To understand this, we need to know that colorectal bleeds expel out the fresh undigested blood in feces. Therefore, we can distinguish that this blood is not coming from the proximal part of the gastrointestinal tract. As well as it is not part of the diet/food taken by the individual. This test is really sensitive and gives a positive result in even very few blood cell detection. So it can be reliable mass population screening. So, after filtering the positive occult blood test cases, we know, not all these people have colorectal cancer. There can be various reasons for the false positive test. Now, another test is employed, which is called colonoscopy. Colonoscopy has evolved a lot over the last few decades. Developing a modality that can reach the various parts of the colon after crossing those sharp flexures was not easy, but now, we have really efficient equipment in this field. Colonoscopy is recognized as a gold standard for visualizing the large bowel. Adenomas can be removed thereby. The specificity is 100%, and the sensitivity is very high. This image is a schematic representation of colonoscopy. It really needs precise and fine coordination of the doctor to perform this procedure. Moving forward to the operative options and the limitation of colonoscopy. Small to moderate-sized polyp can be easily resected during colonoscopy, but T3 or T4 stages cannot be done by this technique. It either needs open surgery or a laparoscopic approach. No tumor can be disturbed, whatever the stage is, if there is lymph node involvement. Radiological procedures like abdominal CT and barium studies can be helpful in detection. Ultrasonography is widely used as it is minimally invasive and has the best patient compliance, but it has diagnostic limitations. CT colonography is very sensitive and helpful in detecting detailed relation, exact size, stage, nodal involvement, etc. But still, colonoscopy has the upper hand as it directly visualizes the lesion. This image illustrates the picture taken during colonoscopy and the 3D model prepared by the CT machine.